Good morning. Today's class is about nonneoplastic diseases of bone. So we'll start with normal structure of the bone and then inflammatory condition of the bone, that is osteomyelitis, metabolic bone disorders like rickets and osteomalacia, osteoporosis, osteitis fibrosa cystica resulting from hyperparathyroidism, renal osteodystrophy, which are the skeletal changes seen in chronic renal failure, and lastly about Pagets disease. Coming to the normal structure of bone, mature bone has two components, cortical or compact bone and trabecular, cancellous or spongy bone. Cortical bone is the dense outer shell responsible for structural rigidity. Microscopically, it consists of layers of lamellae, which are of three types: circumferential lamellae, concentric lamellae, and interstitial lamellae. So each concentric lamella consists of a Haversian canal which contains blood vessels. Adjacent Haversian canals are interconnected by Oakman's canals, and thus they create a rich vascular network throughout the cortical bone. Trabecular or cancellous bone is present in the medullary cavity and has network of slender bony spicules called trabeculae. These traverse the entire marrow space. So this has a main role in mineral homeostasis. It's important to know different parts of the bone because most of the bony lesions, they tend to affect a particular region of the bone. So diaphysis is the shaft or main portion of the bone, epiphysis is the extremities or the ends of the bones, and metaphysis is present in between the epiphysis and diaphysis. This is the region where the growth occurs. Then we have articular cartilage, which is a thin layer of hyaline cartilage covering the epiphysis where bone forms a joint with another bone. Periosteum is the tissue covering the outer surface of the bone. It consists of two layers. The outer fibrous layer is rich in blood vessels, lymphatics, and nerves, and whereas the inner layer is composed of osteoblasts surrounded by osteoprogenitor cells. Then we have the endosteum, which is a layer of osteoprogenitor cells and osteoblasts which lines the medullary cavity. So endosteum also contains osteoclasts. So coming to the composition of bone, it has mainly cells and non-cellular osteoid matrix, which is made up of organic and inorganic parts. Cells are of three types: osteoblasts, osteocytes, and osteoclasts. And the organic part is mainly made up of type 1 collagen, which constitutes about 80 to 90% of the organic component. Inorganic part mainly consists of minerals, and of this calcium and phosphate is the major one. Coming to osteomyelitis, it denotes inflammation of the marrow and bone, virtually always secondary to infection. So it can occur primarily in bone, or it can be a complication of any systemic infection. So all types of organisms, including bacteria, viruses, parasites, and fungi, can produce osteomyelitis, but infections caused by certain pyogenic bacteria and mycobacteria, they are the most common form of osteomyelitis. Pyogenic osteomyelitis is almost always caused by bacterial infections. Organisms can reach the bone by hematogenous spread, especially in healthy children, affecting the long bones. And in case of adults, it is more often as a complication of open fractures, surgical procedures, or secondary to diabetic infections of the feet. So coming to the organisms which commonly cause pyogenic osteomyelitis, the most common organism is the Staphylococcus aureus, which is seen in about 80 to 90% of cases of culture positive pyogenic osteomyelitis. So clinically, cases of patients of pyogenic osteomyelitis present with painful and tender limb, they can have systemic manifestations like fever and malaise. So when you examine CBC, it shows leukocytosis, especially in acute pyogenic osteomyelitis. Radiological examination confirms the bony destruction. So depending on the duration of the symptoms, it can be either acute, subacute, or chronic type of pyogenic osteomyelitis. So now coming to the sequence of the pathological changes. So how exactly the changes occur, morphological changes occur in pyogenic osteomyelitis. So again here the changes associated with osteomyelitis depend on the stage, whether it is acute, subacute or chronic, and also the location of the infection. In acute phase, bacteria will initially proliferate and they induce a neutrophilic inflammatory reaction. So infection begins in the metaphyseal end of the marrow cavity, which is occupied by the pus. Then once there is accumulation of the pus in the medullary cavity, there is increase in the tension, which results in spread of infection along the marrow cavity into the endosteum, and then further it spreads into the Haversian and the Oakman's canal, causing periostitis. Infection can also reach the subperiosteal space, forming subperiosteal abscess. So because of all these changes, they will be lifting up of the periosteum, which will further impair the blood supply to the affected region of the bone. So this kind of a suppurative and ischemic injury can cause segmental bone necrosis, and this results in formation of what we call as sequestrum. Sequestrum is nothing but a piece of necrotic or a dead bone. And then there is rupture of the periosteum, which leads to a soft tissue abscess, which can again channel to the skin as a draining sinus. So apart from this, there can be formation of reactive new bone beneath the periosteum, which is called as involucrum. So this newly formed bone has irregular surface and perforations, and through this there can be discharging sinus tracts. So this is another picture showing chronic osteomyelitis. As you can see, in the medullary cavity there is presence of pus and the sequestrum, which is nothing but a necrotic bony piece, and then you can see the draining sinuses from the onto the skin. So there is spread of the infection from the medullary cavity into the surrounding soft tissue, and then it will cause a discharging sinus. You can see a portion of a resected femur with draining osteomyelitis. So there is a drainage tract in the subperiosteal shell of new bone, that is nothing but involucrum. Apart from that, you can also see the necrotic bony tissue, that is a sequestrum. So there are certain variants of osteomyelitis. One is the Brody abscess, that is, it is a small intraosseous abscess that involves the cortex and is walled off by the reactive bone. Another variant is sclerosing osteomyelitis of Carey. It develops in the jaw with extensive new bone formation. So hematogenous osteomyelitis can present as an acute systemic illness with fever, chills, and then marked throbbing pain over the affected region. So here again, the diagnosis is mainly by the radiographic findings of a lytic focus of bone destruction. So the combination of antibiotics and surgical drainage is usually curative. So when correctly treated, sometimes the symptoms can subside, but in about 5 to 25% of cases of acute osteomyelitis, they fail to resolve and can persist as chronic infection. Apart from that, there can be other complications like pathological fracture, sepsis, and sometimes in the draining sinus tract, it can develop into a squamous cell carcinoma, and rarely it can undergo sarcomatous transformation of the infected bone. Tuberculous osteomyelitis. This is caused by tubercle bacilli Mycobacterium tuberculosis. So it can reach the bone marrow and synovium by hematogenous dissemination, or sometimes there can be direct extension from tracheobronchial nodes into the adjacent vertebra or spread via the lymphatics. The bones which are commonly affected are spine, knee, and hip, and the bony lesions morphologically they resemble the lesions of tuberculosis elsewhere in the body. So they consist of central area of caseation necrosis surrounded by tuberculous granulation tissue made up of epithelioid cells, and fragments of necrotic bone can also be seen. So usually the mycobacterial osteomyelitis tends to be more destructive and also resistant to treatment than pyogenic osteomyelitis. Tuberculous spondylitis or Pott's disease. This is again it's very destructive, and it involves the spine in about 40% of cases. And in Pott's disease, the infection breaks through the intervertebral discs and can in turn affect multiple vertebrae and extend into the soft tissues. So because of this extension of the infection, there can be destruction of discs and vertebrae, which can result in permanent compression fractures. So this in turn leads to the formation of scoliosis or kyphosis. So because of spinal cord and nerve compression, patients can experience some neurologic deficits. Next, coming to skeletal syphilis. So here generally bone involvement is infrequent because syphilis as such is usually diagnosed and treated even before the complications can develop. So syphilis is caused by, as you all know, Treponema pallidum, and one of the skeletal manifestations is seborrheic, which is produced by massive reactive periosteal bone deposition, especially on the medial and anterior surfaces of the tibia. Now moving on to metabolic bone diseases. The first one is the Rickets and osteomalacia. Both these conditions are manifestations of vitamin D deficiency or its abnormal metabolism. So there is a defect in the matrix mineralization, and so there is accumulation of unmineralized matrix. So Rickets is a disorder in children in whom it interferes with the deposition of bone in the growth plates, whereas the counterpart in adults, which is called as osteomalacia, here the bone which is formed during remodeling is undermineralized. So this in turn results in predisposition to fractures. It's a case of Rickets where there is certain skeletal changes, especially like bow legs, then ricketic rosary, pigeon chest deformity, and there can be knock knees, and lumbar lordosis. So the main pathology here is the excess of unmineralized matrix, which results in deranged enchondral and intramembranous bone growth. So cases of osteomalacia, they can present with fracture following trivial trauma, vague bony pain, or sometimes they can have incomplete or green stick fractures. So osteomalacia is the adult counterpart of Rickets. So here again there is the bone which is formed during remodeling is undermineralized. Next, coming to the osteoporosis. So this osteoporosis refers to decreased bone mass, so which is severe enough to significantly increase the risk of fracture, whereas osteopenia means it refers to just decreased bone mass. So in osteoporosis, there is increase in the porosity of the skeleton, which results from reduced bone mass, and this will predispose the bone to fractures. Osteoporosis can be either localized to a certain bone or region, as in disuse osteoporosis of a limb, or it can involve the entire skeleton as a manifestation of metabolic bone disease. There are mainly two major groups. One is the primary and the other one is the secondary. Primary osteoporosis results from osteopenia without an underlying disease or medication. It can be either idiopathic and involutional types. So it is mainly in the postmenopausal and aging because of deficiency of the hormones estrogen in women, as seen in the postmenopausal osteoporosis. So in women of postmenopausal age group, there is estrogen deficiency, which results in acceleration of the bone loss. The decreased estrogen increases the secretion of inflammatory cytokines by blood monocytes and bone marrow cells, and these cytokines stimulate the osteoclast recruitment and activity. So by increasing levels of genes like RANKL, which are again regulators of osteoclasts. So all these factors are responsible for acceleration of the bone loss and osteoporosis in people of postmenopausal age group. Secondary osteoporosis results from underlying conditions as in Addison's disease, hypothyroidism, or in chronic anemia. And even certain medications like corticosteroids, anticonvulsant drugs, alcohol, and large dose of heparin can cause secondary osteoporosis. So when it comes to the morphologic features in case of osteoporosis, there is histologically normal bone, but it is decreased in quantity. So in senile osteoporosis, the cortex as such is thinned out, and it results in subperiosteal and endosteal resorption, and as a result of this, Haversian systems are widened. In postmenopausal osteoporosis, there is also increase in the osteoclast activity, which affects mainly bones or portions of the bones which have increased surface area. For example, cancellous compartment of the vertebral bodies. So the trabecular plates become perforated, thinned, and they usually lose their interconnections, which lead to progressive microfractures and eventual vertebral collapse. So this is a case of advanced osteoporosis. As you can see, there is thinning out of both the trabecular bone and also the cortical bone. So it can also sometimes in the initial stages of osteoporosis, the measurement of blood levels of calcium, phosphorus, and even the alkaline phosphatase are not diagnostic. But it is again a difficult condition to screen in case of asymptomatic people. So the symptoms will not, the radiographic changes will not be seen until about 30 to 40% of the bone mass is lost. So sometimes we need specialized radiographic imaging techniques like to measure the bone density, like quantitative computer tomography, that is a CT, to estimate the bone loss. So main treatment of this postmenopausal osteoporosis or the senile osteoporosis includes exercise, then appropriate calcium and vitamin D intake, which can help in relieving the symptoms of osteoporosis. Coming to osteitis fibrosa cystica, which results from hyperparathyroidism, which causes increased osteoclastic resorption of the bone, because parathyroid hormone normally has a central role in calcium homeostasis. So it can be either due to primary hyperparathyroidism, which results from autonomous hyperplasia or tumors of parathyroid, and secondary is due to prolonged states of hypocalcemia, which can result in compensatory hypersecretion of parathormone. So entire skeleton is affected, and the radiological changes mainly shows decrease in the bone density. Coming to the morphology, in case of hyperparathyroidism, it can cause certain skeletal changes which are related to excessive osteoclast activity. There are mainly three interrelated skeletal abnormalities, that is osteoporosis, brown tumors, and osteitis fibrosa cystica. Cortical bones are affected more commonly as compared to the cancellous bone. So here in hyperparathyroidism, earliest change is the demineralization and increased bone resorption. So for example, in the case of teeth, subperiosteal resorption produces thinned out cortices and loss of lamina dura. And also there will be replacement of bone and bone marrow by fibrosis, along with presence of increased number of bizarre osteoclasts. So this results in moth-eaten trabeculae and cortex. So this is the feature in case of osteitis fibrosa. And because of increased resorption, it results in microfractures, and microhemorrhages also occur in the marrow cavity, which in turn will lead to the development of cysts, completing the morphological picture of osteitis fibrosa cystica. The presence of hemocyte-related macrophages and multinucleate giant cells, which appear at the areas of the hemorrhage, can produce an appearance which is known as brown tumor or reparative giant cell granuloma of hyperparathyroidism. So these are not true tumors, but they usually disappear on surgical removal of this adenomatous parathyroid tissue. So unlike osteoclastoma, they're not true tumors. So the next condition is renal osteodystrophy. So this describes collectively all skeletal changes, all the bone disease that occur in chronic renal disease, including those which are associated with dialysis. So the manifestations of renal osteodystrophy include osteopenia or osteoporosis, osteomalacia resulting from vitamin D deficiency, then secondary hyperparathyroidism, and growth retardation. So as such, the generalized renal failure affects the glomerular and tubular function. This leads to reduced phosphate excretion, chronic hyperphosphatemia, hypocalcemia, and ultimately secondary hyperparathyroidism. So renal osteodystrophy as such involves two main events, that is hyperphosphatemia and hypocalcemia. Next, coming to osteogenesis imperfecta. So these are a group of phenotypically related disorders which are caused by deficiencies in the synthesis of type 1 collagen. So here basic abnormality is there is too little bone, and it affects the joints, eyes, ears, and skin and teeth. And dental abnormalities like small misshapen blue yellow teeth and sensorineural hearing loss are the main clinical manifestations of osteogenesis imperfecta. And now coming to Pagets disease, which is also known as Osteitis Deformans. So it is a disorder of increased but disordered and structurally unsound bone mass. There is autosomal dominant inheritance, and genetic susceptibility has been proposed based on the observation that there is a higher prevalence of this disease in the first degree relatives. And this disease was first described by Sir James Paget. And there has been some evidence that this Paget's disease is a form of slow virus infection, especially by paramyxovirus in a osteoclast. There is evidence about some genetic mutations which enhances the activation by rank signaling pathways, leading to increased osteoclast activity and an increased susceptibility to the Pagets disease. There are mainly three phases in case of Pagets disease. The first one is the initial osteolytic stage, then followed by mixed osteoclastic osteoblastic stage, and finally the burnt out quiescent osteosclerotic stage. In the stage of mixed osteoclastic osteoblastic stage, there will be an imbalance between the osteoblastic laying down of new bone and osteoclastic resorption, so that the mineralization of this newly laid matrix will lag behind, and it results in the development of characteristic mosaic pattern or the jigsaw puzzle appearance of the osteoid seams or the cement lines in case of Pagets disease. The final stage of burnt out quiescent osteosclerotic stage results from excessive bone formation, but here again the newly formed bone is poorly mineralized, and so it feels soft and they are more susceptible to fractures. So when you examine radiologically, this particular stage produces characteristic cottonwool appearance of the affected bone. So, though there is gain in the bone mass, the newly formed bone is disordered in architecture. So, this is the main pathology in Pagets disease. So, coming to the morphology, in the initial lytic phase, osteoclastic activity is increased and there are numerous resorption pits. So, the osteoclasts again persist in the mixed phase, but apart from this, many of the bony surfaces are also lined by prominent osteoblasts. The newly formed bone again is composed of coarsely thickened trabeculae and cortices, which are soft and porous, and they lack the structural stability. So as I told you earlier, the hallmark is the mosaic pattern of the lamellar bone, which is seen in the sclerotic phase. So this jigsaw puzzle-like appearance is mainly produced by unusually prominent cement lines which join the haphazardly oriented units of lamellar bone. So this jigsaw puzzle-like appearance or the mosaic pattern of the lamellar bone is pathognomonic of Pagets disease in sclerotic stage. So this shows the radiological appearance of cottonwool appearance in the final stage of burnt out osteosclerotic one. This is due to the newly formed bone which is poorly mineralized. There is excessive bone formation, but it is poorly mineralized. So this in turn leads to the cottonwool appearance of the affected bone. So coming to the clinical manifestations of Pagets disease, they can either manifest as a monoostotic form of the disease, which may remain asymptomatic, and it can be discovered incidentally or on radiologic examination. Whereas polyostotic form, which is seen in about 85% of cases, they can present with pain, which results from, and also it can result in chalk stick-like type of fractures and some skeletal deformities. And in about 80% of the cases, it is the axial skeleton or the proximal femur which is the most commonly affected bone. So a variety of tumor and tumor-like conditions can develop in these structurally disordered Pagetic bone, like for example giant cell tumors or giant cell reparative granulomas. And lastly, it can undergo malignant transformation to osteosarcoma can also occur in case of Pagets disease. So just to summarize, pyogenic osteomyelitis and mycobacterial osteomyelitis are the main types of the osteomyelitis. So pyogenic osteomyelitis is almost always caused by bacterial infections like staphylococci. So acute infection as such results in neutrophilic inflammatory reaction, which leads to formation of abscess, necrosis of bone fragments, which results in formation of sequestrum, and later reactive new bone formation, which is called as involucrum. And mycobacterial osteomyelitis is caused by Mycobacterium tuberculosis. Spine, knee, and hip bones are the commonly affected ones, and they morphologically resemble the granuloma elsewhere seen in the body. Then osteomalacia is characterized by bone that is insufficiently mineralized, and osteopenia and osteoporosis, they represent histologically normal bone that is decreased in quantity. And hyperparathyroidism arises from hypersecretion of the parathormone and can lead to osteoporosis, brown tumors, and osteitis fibrosa cystica. Whereas renal osteodystrophy represents the collection of the bone abnormalities, that is osteopenia, osteomalacia, hyperparathyroidism, and growth retardation. And lastly, the Pagets disease is a disorder of locally increased but disordered bone. Thank you.